Welcome, everyone. Thanks for joining us for another live event, a Facebook live event for COVID and what we're doing here at the Stram Center. The first thing you may notice is Dr. DiRoma and I are actually sitting together and are not wearing a mask. Um, just to let you know, we are fully immunized and fully vaccinated. Both of us have I received the Pfizer, so did Dr. DiRoma, Pfizer vaccine. We have been immunized for probably about a month now already. We have testing that can actually test for the antibody spike protein, which we are highly immunized against based on our testing. And we've also tested each other for COVID through a nasal swab, and we tested negative. So we feel very comfortable speaking to you all here together. We will put that disclaimer in the Facebook Live presentation as it is. I'm going to first let you hear from Dr. DiRoma. He's going to give you an update on just our current numbers and what's going on with COVID. And with no further ado, here he is.
Yes, good evening, everyone. And, for our second installment here, but really it's probably a different climate than what it was when we last met on January 12th. The numbers were definitely a lot different. The vaccine had really just been approved, and so not a lot of people had gotten the vaccine at that point. But on January 12th, the number of new cases at that time was about 230,000 cases in the 7-day average. So on each day, we were diagnosing about 250,000 new cases in the United States. Currently, as of yesterday, that number of new cases was just under 58,000, and the 7-day average is about 65,000. And really, we haven't seen these numbers since around early to mid-October. And actually, right around January 12th, when we last spoke, that was at about the high point where we were seeing about the highest number of daily new cases. Also at that time, the number of actually fatalities per day were about, on that particular day, was 4,400, and the 7-day average was about 3,300. Currently, yesterday we had 1,300, and the 7-day average was about 1,900. So from January 12th to the present day, the numbers have gone down dramatically. What can we attribute that to? Likely, social distancing has probably helped, and staying at home and everything that we have been doing for the past year. But really, it's likely because of the vaccine, because we had been employing some of these protocols since last year, and really the numbers were getting high and getting certainly out of hand. So it's at that point, I think we were at the tipping point, and now we have the curve is going towards the other end, and certainly we're seeing that in the numbers.
Yeah, so I think, as you all know, I think we're in a different state now. I think we are certainly in where the light is at the end of the tunnel. Certainly these numbers are significant. Vaccinations, as we have for the past, have really encouraged people to get vaccinated, those that can. I think now the numbers are going to open up. The Biden administration has actually had Merck work with Johnson & Johnson to have more of the Johnson & Johnson vaccine, which is a different platform. It's a DNA vaccine as opposed to an RNA vaccine. There are some real advantages to that vaccine, and certainly the portability of it, the lack of a freezer necessary for keeping it stored. It means that it's accessible to much more of the middle to low income areas. One, because you're able to not have very advanced refrigeration or freezing equipment. It is a DNA platform, so that it also is. Um, it's also that it is a vaccine that is a single vaccine, so the likelihood of not having to come back to get vaccinated is also there, and the numbers are good. I want to address some of that. The vaccine numbers for the um, the Pfizer vaccine and for the Moderna vaccine, those numbers are for testing positive. The testing positive rate is about less than 5%, whereas for the J&J vaccine, it's probably somewhere around 30 to 35%. However, if we look at really what we're looking to achieve as an outcome, as a goal, the outcome and the goal of vaccination is to reduce or eliminate hospitalizations, eliminate deaths, and really reduce the morbidity associated with obtaining the disease. And all those three factors, lessening the likelihood of getting severe disease, it's at 85% unlikely of getting severe disease. It is zero. There has been no deaths and no hospitalizations so far when you get the Johnson & Johnson vaccine. So that's really the end results are what we want. So when people ask me which one we would prefer, really whatever is available is the vaccine you should get. They are different platforms. One is a attenuated, meaning it's an altered adenovirus, which is another virus that can cause sometimes cold symptoms and flu symptoms. This is a virus that has been deactivated, and the protein that makes the spike protein is penetrated within the machinery of the adenovirus vaccine. So when it enters into the body sees it, replicates that spike protein, and then we create antibodies to it, similar to what is done with the RNA vaccine. That just it takes out one step. So imagine, you've gotten COVID. Man, that was a rough week of being sick, but you're now into 2 weeks after having COVID. Your breathing is better, you're coughing less, your fatigue has improved, not perfect, and you're starting to count the days where maybe life is going to open up to a normal way. Well, 3-4 weeks into it, and you're still having a cough, you're still fatigued, you may even have some fogginess of your brain, it's hard for you to think. The same task that took you X amount of time now take twice as long, and you're wondering, is this long hauler or long COVID syndrome? And what I'd say is those are the criteria. The criteria, one is that you had COVID infection. 2 is that you have a number of these residual symptoms. And the most common symptoms that we have witnessed is a retained cough, a retained shortness of breath, fatigue, cognitive dysfunction, brain fog, memory loss, inability to think straight, taste and smell that is still not present, and sort of muscle aches and aches and pains in general. And then some people are also complaining of problems sleeping. But those are kind of the most common. And some of the themes that we look at for why is this happening? What is the reason why long hauler syndrome has actually come about? So some of the ideas are, one, that there's still retained virus, that you still have some amount of low-level virus activity in your body, and that is creating an antibody response, a response that you have an infection and your body thinks it still has an infection, but it's using its cell structures to try to kill them. The other is what's called an autoimmune response, which is that your body sees these leftover remnants, this debris of the virus particles, and instead of thinking that it should get rid of them, when it's attached to any of your cells, maybe to nerve cells, since we know that coronavirus has an attachment to nerves. That's why it seems to affect the sense of smell and the sense of taste. That's also the thought of why maybe the long hauler syndrome in the brain with cognitive dysfunction is that it seems to create some inflammatory reaction. So is it that it's now sent out these antibodies in your brain or in your tissue that are fighting against your own cells? So that's an autoimmune type response. Or is it an inflammatory response where your body has produced these cells, these cytokines that are involved in sort of helping your body out, but now because they're being overproduced, they are creating a low level or even a high level inflammatory reaction in your body. What we actually believe, and what Korey and I and Dr. DiRoma and I and Dr. Lee, is that it's probably a combination of all three. And that maybe there is still some low level viral activity, there is some kind of over-responsive or overzealous immune response, and then there is this inflammatory response. And what we believe is that we do have some ability in this practice to try to eliminate or mitigate those symptoms. So I'm going to let Dr. DiRoma kind of add to any of that, to what we were talking about.
Okay. Yeah, so I think the main thing with long haulers may be that we are dealing with something, a virus that is highly inflammatory. And really this is not unlike something that we see with Lyme infections or tick-borne illnesses. So really we have been dealing with the sequelae of infections and chronic inflammatory syndromes really for many, many years, and have developed protocols to really help support the body through this inflammatory process. Some may call it detoxification. We use anti-inflammatory and antioxidant protocols, both by using oral supplementation, but also through IV therapies as well. One therapy that we like to use, certainly for viral infections, for active viral infections, but also for immune support and for inflammation, would be high-dose vitamin C. Now, vitamin C is a very interesting vitamin because at low doses it can be used as an antioxidant and also to help support the immune system. But at higher doses, it actually has more of a viral killing effect, and it's actually more of a pro-oxidant at the higher doses. So this is where we could, again, utilize vitamin C, IV vitamin C, in really two different ways. Certainly, taking vitamin C at home, oral vitamin C is going to have more of an antioxidant and immune supportive effect. And really, with inflammation and chronic inflammation, we want to do two things. One is to decrease inflammation, but also to lessen cellular damage. And at that level, it's really important to have a high amount of antioxidants. So where those antioxidants are coming from, vitamin C or glutathione, amino acids such as N-acetylcysteine, taurine, all of these help to, even some minerals, right, like selenium, they all help to, they're electron donors, so these are antioxidants that help stabilize free radicals and therefore help protect cells from damage to nucleus, damage to mitochondria, inner cell structures, which can definitely cause and lead to symptoms, including shortness of breath, loss of stamina, loss of endurance, fatigue, and chronic inflammatory syndromes such as certainly brain fog and cognitive impairment as well with chronic inflammation. So again, a lot of our treatments are designed to help support this and help decrease inflammation and oxidative stress.
And in addition to that, what's interesting is really when it comes to viruses that do this, we've really not come in contact with this type of pandemic or this epidemic proportions. There are other viruses that we work with and that Dr. DiRoma and I are familiar with, like Epstein-Barr virus, the virus that causes mono, has been known to have a persistent type of inflammatory reaction or chronic fatigue that we see with people that have either reactivated or maintain activity for that virus in the body. And what we think and what we believe is that coronavirus, COVID-19, acts in a similar fashion, that it sort of still maintains activity, so that it still may have some remnants of still active, maybe not contagious, but active virus in the system. So vitamin C we have used in the past in its antiviral and anti-infective aspects. It's used with in sepsis and with people with overwhelming infections. But so I'm going to say that we see this as a very good adjunct to therapy. Another adjunct would be something like NAD. So nicotinamide adenoriboside is niacin in a derivative form. And what we see is that people that have had chronic illnesses tend to have low levels of NAD. So if you supplement it either by oral or by IV routes, you really re-energize, or you repopulate their nutritional deficit with this other supplement, this B vitamin. And I think that what we're seeing is that the people that are benefiting from some of our therapies, it's actually relatively simple understanding of vitamin biochemistry and how the body needs certain vitamins for its metabolic functionings, and especially when it's in a high stress response, like with COVID. So we know that it utilizes B vitamins, magnesium, thiamine, vitamin D, very important in maintaining high levels of vitamin D level, not only because of its calcium, magnesium support, but also because it seems to affect the surfactant of the pneumocytes, which is this soapy portion of our lungs. It's a chemical that allows the lungs to breathe in and out really easily, so it doesn't stick to the sides and get stuck and have micro collapses of the lung, which is what happens with the respiratory distress syndrome that happens with COVID and other persistent infections.
Yes, and other therapies could be like melatonin, which also has anti-inflammatory and antioxidant effects as well. When the body is undergoing chronic stress and inflammation, typically we might get more of a what we call like a aerobic or anaerobic glycolysis, where the cells start to shut down oxidative phosphorylation in the mitochondria, so less ATP and energy is being produced that way, which can lead to more fatigue and low stamina and endurance. But the mitochondria actually also produce melatonin, and melatonin has antioxidant, anti-inflammatory properties. But when it switches from sort of this oxidative phosphorylation to more of a anaerobic glycolysis, then actually what we see is less utilization of the mitochondria, so therefore less energy, but also less melatonin production, and therefore less antioxidant capability and less anti-inflammatory capability as well. So, and obviously it can certainly affect sleep as well. So we definitely recommend taking melatonin, not only to help with sleep, but also to help with inflammation. Another interesting therapy as well that we have utilized, it's actually a medication therapy, and that is naltrexone. And naltrexone is a very interesting medication. What it is It's FDA approved as a opiate blocker, so it's a receptor blocker. It binds. It's a sort of like a competitive inhibitor, so it binds the receptor, but it doesn't allow opiates to bind the receptor. In fact, it can knock them off the receptors a lot like Narcan can when people have sort of a opiate overdose. And what's been found in research is that when the naltrexone is used at very, very low doses, that naltrexone blocks the receptors for only a very short period of time. But during that time, it causes a rebound effect that elicits an endorphin production by the body, and the body actually creates more what we call our endogenous opiates or endorphins. And one of these endorphins, called opioid growth factor, actually has immunomodulatory capability, meaning that it can actually help to reduce the inflammatory response that we see in many inflammatory conditions, including autoimmune conditions from lupus to MS to rheumatoid arthritis, ulcerative colitis, Crohn's colitis, basically all the itises. But what we have also found for our patients with chronic infections who also have this chronic inflammatory response is that this medication can actually help reduce this inflammatory response without suppressing the body's capability of fighting the infection. And that's important because some immunomodulators or immunosuppressant or anti-inflammatory medications suppress the body's ability to fight infections, such as steroids, prednisone, but this actually does not do that. So that's another benefit.
Great. And in addition, interesting enough, a drug that's actually familiar for the Lyme world, which is a derivative of doxycycline called minocycline. And minocycline is a derivative of doxycycline that has a fat chemical on it that makes it better absorbed in fat. And it's very commonly used for acne or for Lyme patients, called minocycline. And minocycline has also been used in long hauler syndrome. So one of the reasons that it's thought of is that because it has maybe this anti-infective but potentially an anti-inflammatory aspect of it that may be related more to its lipophilic properties, meaning how it enters into the cells, that it itself lowers inflammation by both acting as an antibiotic agent, which may mean that there are other infectious agents in the brain that are not being treated otherwise. Just maybe people again have Lyme associated with COVID, but there seems to be a benefit using this drug for long hauler syndrome. And in our practice, and what we've used minocycline for, is typically for people that are, let's say, not getting intravenous therapies, because those can sometimes then enter into the blood-brain, but are getting oral therapies that we want a blood-brain barrier support. And minocycline is one of those. So it's just interesting that that's part of some of the treatment protocols. The other is sort of a common theme with long hauler syndrome. And the common physiologic theme is a lack of oxygen, sort of this poor oxygen delivery to tissues. And do you want to mention anything about that? I know you were talking about that before.
Sure. I mean, there's been some thought and theory that part of the symptoms of the cognitive issues, the foggy headedness, could actually be, and fatigue, could actually be due to potentially lack of oxygen in the brain. And we think maybe if the COVID virus has done some damage in the lungs that has decreased the body's ability to actually absorb and take in oxygen at the level of the alveoli. And so we get potentially the body's less capacity to produce or to deliver oxygen to tissues. So that's where a therapy like hyperbaric oxygen therapy could actually be very useful. And you want to talk about a little bit about hyperbaric oxygen therapy?
Yeah, so I mean, I think what we're seeing with some of our long hauler patients, Lyme patients, is what's called these microinfarcts, which means that they have small little blockages of blood vessels and then surrounding inflammation. And with the use of hyperbaric oxygen, high pressure oxygen in a closed environment at pressures of somewhere around, typically anywhere between 25 and 40 psi. So, in other words, trying to get pressures to, let's say, 2 or 1.75 atmospheres. And so that depth of pressure allows for the oxygen to be delivered across membranes, regardless of the blood flow, to areas of these microinfarcts that can be one in the brain, but also in lung or nerve tissues that are inaccessible because the blood flow is too limited, especially if it's inflammatory. So we believe actually in terms of treatment, hyperbaric may be sort of everything that ties it in together. You've got sort of vitamins that are deficient. You've got the use of high dose vitamin C as treatment, both as an antiviral treatment, antioxidant treatment. And then you have this hyperoxygenation of tissues, which not only does it help with improving the direct oxygenation of those tissues, but it creates longer lasting results. The effect of long-term high oxygen creates actually more blood vessels, so that actually the tissue is even better equipped after hyperbaric to deliver those oxygen-rich blood flow to areas even without getting the hyperbaric because it's already been stimulated to have that occur. So I think what I'd like to say, I think we want to open it up to questions. I think we gave you some information here. I do think we are in this is a different world now. There's a lot more hope. I think that the belief that the world may open up by summer is now not a dream, but a potential reality. And this is now, what are we going to do to care for the people that may have a number of this concerns that they have with having had COVID, the effects of COVID, the effects of isolation. There's a lot of health concerns that are going to be coming out of how we sort of mishandled and now hopefully are handling this disease that will have consequences. At the lowest number that we've seen, it's about a 10% occurrence of people that get COVID long hauler. It appears that it's higher than that because it appears in some studies that anywhere from a third to even a half of people still have residual symptoms. In real numbers, that's talking 3 million to upwards of 10 million people that will have these type of syndromes and symptoms just in the course of this year. So that's a lot. Anyway, want to take your questions, and we will start doing that now.
The first question is going over preparation for the second dose of the vaccine and if there are any additional supplements that should be taken if you have Lyme, Bartonella, etc.
Okay. So Dr. DiRoma and I actually developed a protocol which we've now tried out on actually dozens of patients, and this seems to be pretty effective. It's relatively simple. What we use is glutathione, an oral glutathione preparation. We use an oral turmeric or some sort of herbal anti-inflammatory, either turmeric, boswellia, bromelain combination. So glutathione, turmeric, and quercetin. And quercetin is an interesting bioflavonoid. It acts in concert with vitamin C. It in and of itself has some antiviral properties, antioxidant properties, but one of its other major effects is that it acts as what's called a mast cell inhibitor, which it inhibits the actual cells that make histamine, which is, when you feel really sick or you have cold symptoms, histamine is typically the miserable feeling that you feel, and then antihistamines can help with that. So that's typically what we have people start, a day before their second vaccine. The day of, we typically recommend people to take non-sedating antihistamines, like Claritin is a non-sedating antihistamine, taking between 10 or even up to 20 milligrams per day. The day of, we typically recommend people to actually take either a ibuprofen or Aleve or Tylenol just prior to getting the vaccine. This way, the pain is less. You don't have that sort of heightened inflammatory response. And then if you continue to have symptoms in the evening, we recommend then repeating the Tylenol and repeating a sedating antihistamine like Benadryl.
The next question is asking if we recommend patients with Lyme disease to get the vaccine, and how have our patients with Lyme responded to it?
So we typically recommend that our patients do get the vaccine, even with people with active Lyme infection, because the vaccine is going to protect you against getting COVID. And what we find is that for our patients with Lyme disease, that Lyme is already very inflammatory, highly inflammatory, and getting COVID infection on top of that would actually be worse, right? So we actually do recommend that our patients with Lyme disease do get the COVID vaccine.
In addition to that, what we found is that the people that are actually in active treatment for Lyme disease and get the COVID vaccine, our experience is most of those people do fine with the vaccine. The people that may have more problems are the people that may be dormant. They don't have any symptoms of active Lyme disease. They haven't been treated in months or even years. And now they get a vaccine which stimulates the immune response. And for those people, we have seen some of those people have a relapse of Lyme symptoms. We do think that the protocol that we just mentioned could be helpful for those people as well, because again, it limits that responsiveness.
The next question is asking if COVID will be annual vaccinations.
So that's a good question. I think what we're reading now is that some of the makers from at least Pfizer are already anticipating the need for boosters, and the boosters will likely be a Pfizer booster just because it's much easier to make that vaccine. It's easier to reproduce it, and the end goal is that you're wanting to shift or change the spike protein, which may be the protein that is altered with some of these new strains. And so, yes, likely it would be a booster once a year. That's what it looks like.
Yes, and there are some thoughts of creating boosters to variants as well and getting better coverage against some of these variants. Pfizer has said that the South African variant might actually decrease the antibodies that are produced with the initial vaccine. You could still potentially be covered, but the coverage would be less. So the booster would contain basically vaccination against the South African variant, but also increase antibody production as well. We still don't know yet how long the antibody response is and how long they will last in the system. Typically, after the second dose for the Pfizer vaccine, we have seen that that patients get a pretty high vaccine response or antibody production and activity. And what we can do actually is monitor that over time. So every 3 months, every 6 months, you can get the test and you can see actually where your immunity status is.
The next question is asking if we are going to be getting the Johnson & Johnson vaccine at the center.
Well, you know, we're still actively looking to get the vaccine at this office so that we can provide care and services for our community. We don't know, but likely that would be the vaccine that we would get, only because, again, in terms of storage, it doesn't require the intense storage that the Pfizer and Moderna are, and therefore it's easier to keep on the shelf. That's really the goal.
The next question is asking if patients with persistent Lyme are considered to be eligible for vaccination, even though they might be compromised in their immune system.
Yeah, I mean, and yes, we do. We feel, and we also believe that you are also at greater risk. So we actually think that you are in the immunocompromised form, and therefore should be put at, let's say, an earlier list than someone who does not have chronic persistent infection. So we see that if people are maintaining a chronic infection state, then there has to be some immune issue that's allowing that to continue to occur.
The next question asks if the vaccine will be as effective to get while you are taking antibiotics.
So that should make no difference because it's a completely different response. It's, you know, you're looking for what's called a humoral B cell response to the vaccine. It's trying to view it, look at it, and form an immune response. The antibiotics are there clearly just trying to kill the bacteria and are really not working with that part of your defense system. Right?
Yes, and medications that actually would potentially affect that antibody or immune response would be steroids, certain anti-inflammatory medications, certainly some of the immunologics and biologics for autoimmune conditions, for colitis and psoriasis, rheumatoid arthritis. They typically do suppress the immune response. The thought is to still get the vaccine, but the antibody response might actually be a little less.
Yeah, and what we've noticed is that the people that do get these biological drugs like Humira, Remicade, most often their rheumatologists or doctors in general are telling them to not be on that medication, get the vaccine, and then 2 to 4 weeks, after you've been immunized, to then resume your treatment. I will tell you, for those people, this sort of protocol that we mentioned is very important because for those people, typically there is a flare up of their symptoms once they get the immunization. So what we found is that this protocol really seems to help mitigate some of those symptoms.
The next question is asking if the vaccine is supposed to prevent serious illnesses and death, but not necessarily transmission, will we be seeing a lot of long hauler syndrome even with the vaccine, given the existence of mild or asymptomatic cases?
So that is actually a very good question, and one that we've pondered because that's sort of we're thinking, is this going to create sort of a whole slew of long hauler syndrome? I actually think that what it is even though you may test positive if you have the vaccine, those people in all are generally asymptomatic. And asymptomatic are not the ones that are getting long hauler syndrome. The people that are getting long hauler have had some symptoms. They've had, flu-like symptoms, nasal, so anosmia, so inability to smell, inability to taste. They've had cough. They've had other issues. And then they get long hauler symptoms. The most common is from goes from mild to moderate. And with long hauler, it also seems to be worse as you age. So those that are 30 and get long hauler syndrome do better than those that are 50 or 60 and have more morbidities or more other illnesses associated with them. So I'm going to make a hypothesis that the vaccine will not cause long hauler syndrome. That I don't think it'll happen. But one of the benefits from the Johnson & Johnson vaccine, even though one would not think it's a benefit, is that more people test positive. So like 35% of the people that get the vaccine are testing positive. That benefit is that maybe the herd immunity could be reached faster with the use of that vaccine as opposed to the Pfizer and Moderna, just because more people can still have some infectivity.
The next question is regarding our thoughts on developing Bell's palsy through vaccinations.
I believe Bell's palsy and vaccinations with the COVID vaccine, there have been a few cases, and typically, again, it's an immune response. So Bell's palsy, for those who may not know, is a condition that where an inflammatory or an infectious process actually affects parts of the facial nerve. So you get oftentimes half of the face where part of it may droop, like your eyes or your mouth. And we tend to see this actually with Lyme infection and with other viral illnesses. And oftentimes conventional treatment may actually be anti-inflammatory agents. So an immune response towards a vaccine potentially in people who may be susceptible could cause this symptom of Bell's palsy, but it has been found to be very, very rare. I believe there have been less than a handful of cases, and so far in the U.S. there have been almost 52 million first doses given, and to really have just a few cases of Bell's palsy out of 52 million is a very, very small amount.
The next question asks, if you are on LDN, should you not take it the day of your vaccine?
It should not make a difference.
Right. So LDN, again, doesn't have a very strong immunosuppressive effect, and it should not make a difference. You can take your LDN dose. It actually could potentially help decrease the inflammatory response. Dr. Stram was saying earlier about our protocol with quercetin and glutathione and turmeric, but also potentially it becoming more symptomatic, achy than potentially Tylenol. But again, LDN, if you're on it, could actually help reduce some of those symptoms as well.
The next question says, being that the COVID vaccine contains human DNA, are you concerned the vaccine could cause an autoimmune disease?
Okay, so one, the vaccine, so both the mRNA vaccine is a vaccine that is a piece of the virus. It's actually not a whole virus. You can't get the virus, you can't get sick from the Moderna or Pfizer vaccine. It is not a piece of DNA, it's a piece of RNA, so it's not a DNA part. So DNA could enter into the nucleus, the RNA cannot enter into the nucleus. Just to clarify, the Johnson & Johnson is a DNA platform, a DNA virus platform from an already manipulated adenovirus that all its machinery for infecting us has been taken out. So it has no infective aspect of it. And what has been penetrated or spliced into that genomic structure is the spike protein. So none of that is a DNA type human DNA that can potentiate more of our own cells. That just isn't true.
The next question is regarding the new strains and the research about how they help with the current vaccines.
So the new strains, one, are not really new. They're almost the strains that are here now. The UK variant is, I think, in some reports in New York City, it's 70 or 80% of all the strains that are being seen. That is the most common strain that is in Israel. And Israel, as of now, is the most vaccinated country. And because of that, we're able to have more data from that. So that country is, I think, it's now between 50 to 60% of its whole population is vaccinated, and up to 80% of their people over 65. The data on that is that those that have the vaccine, not one of them, died. There were just very limited hospitalizations, and the transmission rate between those that got the vaccine and those that don't, the transmission rate was dropped by somewhere about 75%. So I think those are all really good findings and good signs that this is an important infection to get vaccinated, because this is not the typical virus. Right? This isn't a typical flu virus. Flu does not cause long hauler syndrome. It doesn't cause these type of responses that we're seeing with long hauler syndrome and like persistent Lyme disease. Mm-hmm. So I think that this is a more significant infection to take seriously.
Yeah, and something to add, just the way that viruses are, viruses need a host to replicate, and they can't do so if somebody is vaccinated and they can't get in, they can't replicate. So variants actually come about because they are infecting people, and as soon as we get more people vaccinated and protected, then we actually decrease the chances of these variant and genetic shifts.
Right, and that's why, in addition, this isn't just about us. This is about the world. We want the world to get vaccinated, because more of the world is vaccinated, less of these variants are going to come out, because that's how they come out. And that's why they have been coming out so rampantly, because so many people are infected.
The next question asks if the vaccine can activate Epstein-Barr disease or the herpes virus.
The vaccine activating other viruses, I don't think we've seen that necessarily. I mean, theoretically, it's possible, especially with Epstein-Barr virus, because Epstein-Barr virus actually does hide in B cells, and B cells are your precursors to antibodies. So sometimes when we do see people having infections and needing to create a lot of antibodies, we might actually then see potentially a reactivation of the virus. But clinically, we actually haven't seen that, and I haven't had any patients that have presented with a reactivation of mono. Oftentimes harder to discern because the symptoms may be a little bit more vague, such as fatigue, maybe scratchy or sore throat, swollen lymph nodes. But herpes simplex virus, or shingles, any of those types of viruses, you're actually going to get a rash or lesions, and we haven't seen that.
No, we haven't seen that, but I would say, in addition to what you said, Dr. DiRoma, it's also about the circulating immune complexes. So circulating immune complexes are the antibodies that you want to form from the vaccine. If there are an overabundance of these circulating immune complexes, they could cause the same sort of symptoms that you may feel from chronic fatigue, chronic, fibromyalgia or pain syndromes. So it can do that. And what we believe is some of the supplementation that we're talking about is really to try to mitigate or release or or relinquish some of those side effects.
The next question is asking, if you've had COVID, is it possible to have extremely high vitamin B levels? This person did not test positive, but they had antibodies.
So this person did not test positive for the COVID virus.
But
so
had antibodies and
right.
also had symptoms.
So, I mean, I'm going to say that is that, whether the test was accurate, the test is, it's about, the right sample. Was there enough mucus on the sample that you had enough of the virus particles to test positive? Was this really just a false negative and you actually had COVID? This is very common. There's been a rush to test, so I don't believe the testing is as accurate as one could hope. So it may be, 80% accurate, 70% accurate. And so you may have just not tested positive. I believe then if you have antibodies and you didn't get the vaccine, then you had COVID and we just tested negative. So I don't believe that you didn't have any of the potential issues.
So the elevated vitamin B levels, she was wondering if it could have been from COVID.
So likely the elevated vitamin B levels may more be from the fact that you're not detoxifying or processing your vitamin B. So it's maintaining in solution, and there are in solution meaning in your blood and not getting into your tissues. So there is a level that's called the methylmalonic acid, or MMA, which can detect if you have put this group, this sort of chemical group, on the vitamin that allows it to get into your tissue and then function as appropriate B vitamin. If that level is very high and you also have high levels of B vitamins, the likelihood is it's really that you have low levels of the B vitamin in tissue and that it's circulating in your blood. And that could be because of COVID causing such a high response, a high need for your tissue B vitamins, that it sort of consumed that and left you with this leftover B vitamins in your blood that aren't being processed.
The next question asks if the COVID infection itself can trigger autoimmune diseases.
So we think, and I think both of us think that it does do that, because I think that that's some of the long hauler syndrome is more of this autoimmune response, because it's occurring 3 weeks, 3 months later. That's how long it takes antibodies to form. So I think that kind of goes along with that. And I do think that is probably happening. And that is what we see with Lyme disease. So we see people that will have, sometimes they'll have an autonuclear antibody positive, then they'll have certain other rheumatoid factors positive, and then it'll go away. And so it'll be intermittent. And we think that that's because of the rise and fall of the bacterial titer, but with COVID, it could be the rise and fall of the viral titer, or it could be the rise and fall of the inflammatory proteins.
The next question asks how long someone could be a long hauler.
It's not called long hauler for nothing. No, I'm kidding. I think we don't know, because this is a new disease. It's new since really April, May of 2020. I mean, it's only really been seen because of really people like you in the audience that started web groups and chat sites that were describing symptoms of a lot of symptoms that a lot of Lyme patients have, which is, I've gone to 10 different doctors. They told me it's in my head. No, you don't have COVID anymore. We tested you. You're negative. It must be a psychiatric symptom, psychiatric illness. Yeah, it's a lot of stress. Yes, we're all under a lot of stress. Take some antidepressant. You take it. You still don't get better. So then that's when people started to pay attention. The good news is the NIH is paying attention, and that there is significant funding for the long hauler syndrome. Unlike the funding for Lyme disease or persistent infection, there is $1 billion in the tool chest to try to figure out how to treat this and what's the cause. So I think some of that we'll get a lot more information. And I'm going to say that I really hope that this will migrate into the persistent Lyme community for assistance in treatment and maybe even laboratory diagnostics.
The next question asks, if you have thyroid issues as well as Lyme disease, would the vaccine be effective or an option?
With thyroid disease, hypothyroidism, which one main type is actually an autoimmune thyroiditis known as Hashimoto's, which is inflammatory. Also, Lyme infection is inflammatory. Again, I think it's best to get the vaccine, because if you get COVID on top of having these other inflammatory issues, it can certainly make those problems potentially worse. And we haven't seen any issues with getting the vaccine for those particular health conditions.
For the last question, someone asks if people with chronic Lyme should receive either the Moderna, Pfizer, or Johnson & Johnson vaccine, or if it does not matter.
So, I'm going to just give you my response to this is, if you were told you can get the vaccine tomorrow, get the vaccine tomorrow, whether it's Johnson & Johnson, Moderna, or Pfizer. If you could choose, there may be some that are better than others. I think right now we know a lot about the mRNA vaccines and what they did, and Pfizer specifically. So if you said, you had a choice, I'd probably say the Pfizer vaccine seems to stimulate sort of what it seems to be is the best immune response. But I'm not sure if any of them would be any worse or better. The fact is right now you want to develop this antibody response to this virus. And every one of those vaccines does that. It gives you an antibody response. And the Johnson & Johnson seems to give a robust response with just one dose. And you don't really seem to be able to get that robust of a response if you only were able to get one dose of any vaccine. I would say that Johnson & Johnson would be the vaccine you get. Since the Moderna and the Pfizer are 2 doses, and you can get that, then that's great. But if you only have the ability to get one vaccine, then the Johnson & Johnson, just because of ease of getting it. Thank you so much, everyone. It's always a pleasure to sort of speak to the people that we care for. It is with great privilege that you trust us in your care, and we hope to continue to provide care for you and for our community in the months and years to come, when we are really over this very terrible and difficult time in our life for the pandemic. And I can't wait to see you in the summer and maybe even say hello with this kind of face without a mask.
Yes, thank you everybody for joining us tonight, and have a good night.